So I'd like to invite our first speaker, Brian McMahon. Maybe just give everybody a little background of the work, where you work and what you've been doing. He's going to highlight his work in Africa.
Thanks. I'm Brian McMahon. I'm a hepatologist and an epidemiologist. I've been working in Alaska since the early 1970s, and I run the viral hepatitis and liver disease program at the Alaska Native Health Consortium, and we've been working on hepatitis B, C, and A, and we've actually reached the 2030 goals with hepatitis B probably a decade ago or more. But in addition to that, I got involved, I got asked by the CDC to get involved in a program in Africa on HIV hepatitis B a decade ago. And then we actually finished that program and then started a program on monoinfection with hepatitis B. And the way that program got going is because people would go to the blood bank in Africa to donate blood, or at the hospital to donate blood. And they would find out, they would be tested for hepatitis B, hepatitis C, HIV, and syphilis. And if they had syphilis, they just bend over and do a shot, and that's that. That HIV got linked to the HIV program. If you had hepatitis B or C, they said, well, go to the hospital and see what they can do for you. And they went to the hospital, they said, we can't do anything for you. We don't know what to do. So we decided to get some funding through the CDC Foundation to start two model monoinfection clinics that follow the WHO guidelines and see how well they went. I was the co-chair of the WHO guideline committee in 2015, and so we wanted to see if we could implement those guidelines and train people on how to follow them and how well they would work. So I gave you all a handout, and so very briefly, the program was to establish two clinics of excellence would implement the hepatitis B management and treatment programs in Nazi Mojo Hospital in Stone Town, Zanzibar. That was staffed by internal medicine and family physicians, and they had a lot of experience working in the HIV program, so they were experienced at managing chronic infectious diseases. The other one was in Mumbai in Dar es Salaam. That's the major medical school there, staffed by gastroenterologists and GI fellows. And we wanted to implement a model care and treatment program and then evaluate the feasibility and acceptability by patients, facilities, the government, and then look and see what was the outcome of that, looking at improvement in liver function tests and hepatitis B virus DNA, and also to train and increase the capacity of the healthcare workers to care for patients with chronic hepatitis B. So the project is from January 2017 to December 2021. And we're enrolling patients that are 18 and over, and most of the people are coming from the blood banks, but also from the hospitals and clinics. And we're only taking people with monoinfection, and that little recruitment guide just kind of shows you how we go through and pick out the select people who are going to be in it. So people that are eligible for treatment have APRI of greater than 1.5, elevated ALT, that's 2 times the upper limit of normal, and an HBV DNA greater than 20,000. Or one or more of the stigma of liver cirrhosis, which are listed in that little table there. So what are the results? Well, we have, our goal was to recruit 2,000 people. We recruited 2,052, so we stopped enrollment. And we are looking at how many of those patients had advanced fibrosis, and what was kind of shocking is that 257 of those patients met the criteria for advanced fibrosis. And we found 41 patients of hepatocellular carcinoma. And because the hospitals decided they wanted to do ultrasound in additional, that wasn't part of the program, they do an ultrasound and they found 41 cases of HCC, which is a little bit on the tragic side because there's nothing they can do. They don't do surgery there. If you have money or if you have a connection with the government, they'll send you to India for a transplant, and you'll pay $80,000 for it, which is vaccinated a heck of a lot of kids for $80,000 at birth. And incidentally, by the way, they are not vaccinating children at birth in Tanzania or Zanzibar. And then they've already had 17 deaths from complications of hepatocellular carcinoma since we started. We found that 241 people met the treatment eligibility, and part of the program was to furnish them with TDF for forever. And 175 have already been started on treatment, and 4 patients that were started on treatment that had advanced disease expire. So we can see on that graph there that how many are enrolled at each of the sites and how many are treated. And you can see that we are really early in the project and we still have a lot of people that have to come back for their second, third, fourth, et cetera, visit. And the next thing are some graphs to show you that this is having an impact. So the first graph is just looking at the APRI scores, and the gray bar there is from Stonetown, Zanzibar, and the blue bar, the lighter blue bar, is from Dar es Salaam. You can see that compared to people who weren't treated, who had a lower APRI, of course, because they didn't qualify, the APRI has really fallen. But more dramatically, as you look at ALT scores in Zanzibar, the average ALT was between 200 and 250. That's really high. These are people who were asymptomatic and didn't know they had hepatitis B. And that ALT score has already dropped down on the fourth visit to the normal level. And the same with Zanzibar. With Dar es Salaam, it wasn't quite as high. It was 100, but it still dropped down by visit 5 to the normal level. And finally, the mean HBV-DNA level. We are doing HBV-DNAs at enrollment, and you can see impressively that in Zanzibar, the average level was, I can't even read that, I think it was 14 million, and it dropped down by visit 3 to close to non-detectable. And then in Dar es Salaam, it was 12 million. So this works very well. One thing we've learned is that I think 20,000 is too high. I think we should be using 2,000 because we found patients that had between 2,000 and 20,000 that had very high liver enzymes, and they were potentially going to get into trouble fairly quickly. So I think the WHO guideline needs to look carefully at lowering the cutoff to 2,000 and maybe making it a little more liberal for ALT instead of twice the upper limit normal, maybe just an elevated ALT with the level of 2,000. We follow these patients every year, and so we'll keep tuned, and we'll give you more information later on.